Hello and welcome to Paincast, Conversations on Pain and Physiotherapy. This podcast is brought to you by the Pain Science Division of the Canadian Physiotherapy Association. I'm Tiffany, the host of Paincast and an executive member of the Pain Science Division. I practice physiotherapy in Toronto. What is the relationship between knee osteoarthritis pain and the stages of the disease? What are the different pain patterns? What is the role of pain system sensitivity and self-reported measures in subgrouping people with knee OA? Join me and Dr. Lisa Carlesso in exploring all about knee OA pain. Before we start, as a reminder, Paincast brings together researchers, clinicians, students, and patients to facilitate discussions, knowledge translation, and critical thinking on topics about pain and physiotherapy. The views expressed in each episode are of individual guests, do not constitute medical advice, and do not represent the views of the Pain Science Division or the Canadian Physiotherapy Association. Enjoy the episode. Hi, Dr. Lisa Carlesso. I'm so happy to be able to talk to you about knee osteoarthritis pain today. How are you doing?
I'm great, thanks. And thanks so much for having me. And great to be back on the Paincast after many years.
Yes, Lisa was a Paincast host, so I am an honored successor. To start us off, can you introduce who you are, what you do, and what a typical week looks like for you?
Sure. So I'm a physiotherapist by background, and I worked for, close to 25 years. And I started my academic journey about halfway through that. And so now I'm a professor at McMaster University in Hamilton, Ontario, Canada. And I primarily research knee osteoarthritis with a focus on pain mechanisms and trying to understand how that understanding can inform different aspects from treatment to just disease progression and onset and things like that as well. So kind of a large umbrella, which is focused mainly by pain mechanisms.
Can we just briefly talk about what knee osteoarthritis is?
Yeah, that's a good question. Because I think there's a lot of misunderstanding actually that continues about it. And its current understanding that we have had for a little while now, I'm not sure that the message is really getting out there. So, there's been a real move away from describing it as a degenerative disease, a disease of wear and tear. And what we've come to understand over the past several years is that it is a disease of the whole joint and it affects all the tissues. And it's really a disease that occurs because of joint failure. This normal process of regenerative and these mechanisms that constantly rebuilding, that balance that is typically there is lost. And so unfortunately, it tips towards the negative, and that's where things start to change. So, it's understanding that it affects all of the tissues is important. It's not just a cartilage-focused disease. I would say another piece we've known for quite some time now, but that's really come into focus more is its inflammatory component, that it does have this low-grade inflammation that drives a lot of things. So there's a lot of different subgroups that exist, which makes it challenging to treat. So it's really hard to say that knee osteoarthritis is one thing in particular. It can be quite different from one person to the next, and trying to figure out how that person is presenting and what they need most as far as treatment is concerned is what really the current challenge is.
So, given there's different subgroups, in your research, why is it important to further our understanding of knee osteoarthritis pain?
As with many musculoskeletal disorders, there's quite a heterogeneous presentation, and in order to tailor our treatments to the person sitting in front of us, it's best that we can find a way to personalize that as much as possible. And so by looking at subgroups of people in the research that we do, we can try and make that connection clinically, right? So we want to know people who have effusion synovitis, what works for them, right? People that have more of a mechanical weight-bearing presentation, etc. So there's different things going on that when we try and define what those groups look like more and who is at risk to be in those groups, what the typical clinical presentations are of these people, then we can tailor our approach and know more about their prognosis, etc. Like I said, when there is such heterogeneity, it's really important to try and make as much sense of it as possible. In terms of pain, we have people that have not too much pain. It's intermittent. It's not of a high intensity. We have people at the other end of the spectrum that have really high, constant pain. And so trying to understand why that is and what are the things that are contributing to the differences in these people's pain so that we can, again, help find solutions for them that are effective, which we are currently lacking in quite a bit.
Yeah, because from my understanding, the current recommendations for management, mostly we have different types of exercise, with land-based exercise being probably the most effective and so on. And we don't really have diversified recommendations based on different subgroups. Do we currently have?
Not for exercise, no. One of the guidelines that came out a few years ago did try and do a bit of subgrouping based on, for example, people that have widespread pain or clinical depression, that kind of thing. But what is at the core of the guidelines is that exercise education and potentially weight management, if necessary, are kind of core elements that can be applied across anybody. As far as exercise is concerned, that evidence has been a bit upended in the last little while, in the sense that we had two very robust systematic reviews come out that have now said that exercise has very small effect sizes and is potentially not really clinically meaningful compared to non-exercise controls. And so that really kind of sent some interesting chatter through the academic and research world about what we do with exercise. And, there's lots of benefits, obviously, to exercise. And within people with knee osteoarthritis, we know that it greatly affects their mobility. And when people stop moving, they start having all kinds of other health problems, right? And there's all kinds of comorbidities that develop. And there's associations in people with knee osteoarthritis with all kinds of other diseases, multimorbidity, and even mortality. So exercise is absolutely important. It has much larger importance than just helping manage pain. So we certainly don't want to give the idea that exercise isn't good to do. But as far as the effects of exercise for pain management and even function, we do have a lot of work to do where people are going back to the drawing board and trying to figure out where that evidence base needs to go. What are the most important questions that need to be looked at, and really trying to plan out the future.
Just what's so striking to me, a lot of research has been done on knee OA and a lot needs to be done. That is very intriguing. So back to the topic today about knee OA pain. Your line of research regularly involves what's called quantitative sensory testing. And this is going to be important for our audience to understand before we further our discussion into knee OA pain. What is QST?
QST, another label for it, is psychophysical testing. So it combines the psycho part, or the psychological part is the kind of subjective self-report aspect of pain that we can never get away from. But it is using standardized instruments and physical assessment of a person's sensitivity to these varying types of stimuli that are introduced using these instruments. So it's a way to try and get this standardized assessment using these tools. And within knee osteoarthritis, we focus on a few of them that we have found over the evolving evidence that have become more salient to this population, I'd say. But generally, there's a range of modalities and different frameworks as well. So by modalities, I mean we can use pressure stimulus, mechanical stimulus, thermal and heat or cold stimulus, even electrical, chemical. They're used certainly in my line of research, far less common. And then frameworks refers to some of the different testing frameworks that we use. So there's a test called condition pain modulation, which is a framework that uses pain to inhibit pain. And it kind of combines different QST measures. Temporal summation is another framework.
Just to help our audience sort of visualize, how do you measure these frameworks? Can you briefly talk about how you would?
I'll talk about the ones that we do most often for knee osteoarthritis. So we use pressure pain thresholds. So we use a pressure algometer. It's a handheld device. There are some automated devices out there, but most people use a handheld device. And it has a digital screen on it and a rubber tip. And what it allows us to do is we apply the rubber tip to the patient, and we have to try and do that in as standardized a way as possible. So we will often use a metronome. When I'm training my students, I'll have a metronome on so that we can hear that 1 beat per second, because we're aiming to induce the pressure at a certain rate to make it replicable. And it takes lots of practice to be able to do that. And seeing the screen and the digital readout allows us to know how quickly we're applying that pressure, so that there's like a feedback mechanism there. What we're looking for, as I said, is a threshold test. So we're looking for the moment at which the sensation of pressure changes to one of pain. And usually we just ask the person to say now or pain or something, some verbal indicator. There are, again, some units where the person might have a button to push the moment they want that to be registered. But for the most part, with these handheld units, people are just verbally indicating. And then we stop the test and we will have a numeric readout corresponding to their indication of that threshold. And that's what we record.
And briefly, temporal summation, what does that mean? How do you measure?
So that's an indicator of a phenomena called wind-up, which occurs in the spinal cord. And again, so because it's a framework, we could use different modalities. You can do temporal summation with a pressure stimulus, you can do it with a thermal stimulus, etc. The idea behind it is that the summation part is that you're repeating this stimulus in a standard way. So what we do is we work with mechanical stimuli most of the time for the knee. So we will use a weighted probe and we will introduce it to the patient and we just kind of tap it once. And I should say too that the protocols for these things are all over the map. So someone could do a few taps or just one tap, and then we ask a person for a pain rating. After that initial pain rating is given, we then repeat that for at least 10 seconds, one stimulus per second for 10 seconds. Again, some of the protocols will go up to 30 seconds or even a bit longer. And then when that period of time is done, we ask the person to rate their peak pain that they experienced during that time. And then we subtract their initial pain rating from their last pain rating to give us a value. So we're looking at the change in their pain rating over time, over that 10 seconds or 30 seconds. For example, if somebody said 1 after the first poke and then they said 5, then their pain rating would be 4, and we would consider that a positive test. Because the fact that their pain rating has increased, it is essentially summated over those repetitive stimuli that we applied.
So just to give a brief summary, we have pain pressure threshold, understanding what amount of pressure would the person constitute as pain. So that is an indication of pain sensitivity, is that correct?
We like to think of sensitivity in terms of it occurring in the peripheral nervous system as well as the central nervous system. And it's important to understand as well that these tests are surrogates in humans. So we cannot know for certain because we can't cut into people and look at what's happening in their spinal cord, for example. These are truly tests of sensitization. We say it's human assumed sensitization. So when they do these tests in animals, and usually in rats, for example, they are able to do that, to look right into the nervous system apparatus and see what's happening to confirm, in fact, whether there is sensitization present or not. And so this is kind of, the best surrogate measure that we have, and it's been used for a number of years now across all musculoskeletal disorders. In terms of peripheral sensitization, we're trying to get an idea of sensitivity in the peripheral nerves to that stimulus. So, for example, if I was going to do a pressure pain threshold test at the knee, and at the affected knee, assuming there's only one, then that would be an indicator of sensitization in the peripheral system for that person. Versus if I was going to do a pressure pain threshold in what we would refer to as a remote site, so I might go to the opposite forearm, for example, or the trapezius. People do different sites, but these are considered to be quite far enough away from the knee that we are now going through the central nervous system. And so that would be an indicator of sensitization of the central system. And the temporal summation test, as I said, it happens at the spinal cord. So no matter where you do it, it is considered a test of central sensitization.
And you said conditioned pain modulation is using pain to modulate pain. Elaborate a bit more. How do you measure that?
It combines usually two different modalities. The idea is that you have what we call a test stimulus. So we start out with the test stimulus and we finish with the test stimulus. For us, again, I might use the pressure pain threshold test at the beginning and at the end. And then in between, we're going to insert a second stimulus. And what's important about this is that second stimulus we refer to as the conditioning stimulus. And it needs to be at a sufficiently higher intensity than the test stimulus. And the reason being is that it has to create sufficient distraction, if you will, in your nervous system to create an effect. So, for example, again, as I said, there's different kind of paradigms, ways to do it, or I shouldn't say ways to do it. Conditioned stimulus, test stimulus is essentially the paradigm, but the modalities that you use could be different. So one of the ways that we do it is we will do pressure pain thresholds as the test stimulus, so before and after, and then we're doing something called a ischemic forearm test as our conditioning stimulus. What we would do is, for the conditioning stimulus, is we blow up a blood pressure cuff slightly above systolic pressure, and we have people squeeze a stress ball for up to 2 minutes. And we're looking for their pain in their forearm while they're doing that to get to like a 4 or 5 out of 10. And we're looking for that intensity because when we're doing a threshold test, because we're looking at the moment that the sensation changes to pain, that's really looking at a pain intensity of a lower number, right? Probably like a 1 or a 2, because it's just becoming pain. When we do the conditioning test, we want it to be higher, which is why we're looking for like a 4 or 5 type of thing. A lot of people will use what's called a cold pressor test for the conditioning stimulus. We've also used that. And that usually involves, depending on what part of the body you're testing, putting a different part of the body, immersing it in ice cold water. As you might imagine, quite a pain response, especially when you have to stay there until, your pain gets sufficiently to whatever, again, like 5 out of 10 or something, right? What we do with that test is similar to temporal summation. We look at the before and after ratings of the test stimulus. Again, there's been different kind of ways that people have calculated that, but ultimately what we look at is that it's telling us something about the efficiency of the descending modulatory tracks. That means that often we'll structure the calculation that positive numbers mean that the system is working efficiently and negative numbers mean that it's inefficient.
So, we've talked about how in the research setting, we have these tests as surrogates of how the pain system functions in a participant. So we can sort of understand whether there is central sensitization, peripheral sensitization, and how effective a person's pain system modulates pain. Okay, now that we've understand it, let's talk about all the pain research that you do. So the pain patterning side and the pain phenotyping side we'll get into. First of all, when we talk about osteoarthritis pain, there's a lot of research to suggest that imaging findings, meaning what you see on, let's say, X-ray of someone's knee, correlate little with their pain experience. What does that actually mean and why is that?
Again, it's a really interesting point, and it's always, something that gets brought up. When we're looking at that association of imaging with people's pain, we're looking across a lot of different individuals most of the time. And as we know, everybody's pain experience can be very different from one person to the next. And we know that pain is not just a biological phenomenon, right? It's not just about the structural changes in my knee. There's cognitive, emotional, social elements to it. And those distinctive factors for each individual will introduce a lot of heterogeneity in the person's pain experience. So when we're looking across individuals and we're trying to, look at that association, that makes that more challenging to understand, right? Because a lot of things are going into that person's pain intensity, for example. There was a really interesting study done several years ago now by one of my collaborators, Tahina Nioji, who's at Boston University. She did a study looking at people with both knees. Okay, so it was what we call a knee level analysis as opposed to a person level analysis. She was able to show that when you're comparing knees and then you're essentially controlling for the fact that the same person has those two knees, right? So it levels the field, so to speak, for all those cognitive, emotional, etc. factors that get brought in. She actually was able to show by doing the analysis in that way that there is actually quite a strong correlation of pain with changes in the knee on X-ray, and that it also is linear with progression of the disease as the changes get worse. So I think, that's really important to keep in mind that when we're looking across individuals, there's a lot of things that are being factored into that pain that we can't account for necessarily. We do know through some other studies, as far as structural changes are concerned, effusion synovitis and bone marrow lesions are two of the features that have been coming out that do have a more consistent association with people's pain than, say, for example, osteophytes or joint space narrowing, cartilage degeneration, that kind of thing.
That's really interesting. I remember seeing a case of a patient with hip OA and both hips were imaged with X-ray, and with X-ray you can usually just see osteophytes and joint space narrowing, and the hip with more joint space and it appears less osteoarthritic, that hip is the painful hip versus the other one which has a more severe change on X-ray. But it's an interesting point to note, as you said, the two things.
The effusion synovitis and bone marrow lesions.
Yeah.
But that's specific to knee osteoarthritis. But yes, yeah.
Yeah. No, that's very cool. So I think when clinicians think about imaging findings and how that correlates with people's pain experience, we're tempted to say to people, well, actually, your pain doesn't have to be dictated by how it looks on X-ray, for example. Do you think it's still valid to say that, or would you recommend another way of phrasing our pain education?
I think it's really important that people have a good understanding of what pain is, all the different aspects of it, so that they don't just focus on their imaging findings. I mean, I'm a good example myself. I have an arthritic knee because I had a ACL injury when I was younger and they took out all my cartilage. It was all torn up. I am still quite active. I don't have a ton of pain unless I do things that I know are going to kind of flare it, so to speak. I think we still, unfortunately, there's lots of people that I'm encountering, certainly that are coming to my studies and are saying that they've been told by their healthcare practitioners that they have bone on bone. They have a knee of a 90-year-old. It's amazing they can still walk, this kind of stuff, right? And this type of language, absolutely, I believe 100% has nocivic effects on people. I think we really need to make an effort to try and get away from using any kind of language like that. Try and really read imaging in a way that uses neutral language that is a more accurate representation of what's going on. Often, a lot of these changes that we see are normal within the context of a person's age, right? And so that normality is important to communicate. But when we can teach people about all the different aspects of a person's pain experience, that there are cognitive aspects, emotional aspects, that they can learn more about what pain is and they can help understand how these things can impact them on a day-to-day basis. They can notice that when they're playing with their grandchildren, for example, that, amazingly, they don't have any knee pain and they can maybe tolerate crouching down or kneeling on their knee, which if they were doing that to scrub their kitchen floor, it would be very painful, right? So I think there's absolute value in making people aware of what pain is, all the different aspects that can go into a pain experience, try and bust a lot of the myths that people come to associate with pain. And yeah, I think the more knowledge that people have that way, the better, so that on a day-to-day basis, they can learn to, kind of understand what they're experiencing, why they're experiencing, and hopefully learn not to be too concerned about it, right? So that in our case, that their knee is not falling apart, it's not going to be brittle, and they're not going to be doing more damage to it, this kind of thing, right? So it's something that we have to spend time on, and it's very worthwhile for the person and for helping shape their experience going forward.
Yeah, spending time to educate them what pain is, that is a huge part in helping them manage the pain. One of your research on pain patterns in knee osteoarthritis is interesting because we just previously talked a little bit about how stages of knee osteoarthritis can influence your pain experience based on the Boston U knee level analysis. You also find different pain patterns. Can you talk a bit about that?
Yeah, so again, there was some really interesting qualitative work actually done by Dr. Gillian Hawker in Toronto, a rheumatologist there. They interviewed, I don't know, it was hundreds of people globally, actually, about their pain experience. And I believe it was people with hip and knee OA pain. They basically just asked them about their pain experience and what it was like, had them describe it and the different qualities and aspects of it. And what they heard and were able to document was that people who are in the earlier stages of disease have more of an intermittent pain experience. So the pain comes and goes, and it seems to be related to physical activity more. There's usually some type of physical trigger for it. As the disease progresses, that intermittent pain can become more frequent, and often it can also become a bit more intense. Even further along the disease line, it can switch to becoming more constant. From this work, she developed a new self-report measure called the Intermittent and Constant Osteoarthritis Pain Scale, or the ICOAP, ICOAP. It has an intermittent pain subscale and a constant pain subscale. And it's been able to provide a new dimension rather than just pain intensity, as we all like to use, of measuring that pain experience. We did a study where, based on the qualitative work, where people were describing, as I said, intermittent pain seemed to be occurring more in people with early disease and then constant with later disease. We did a study where we looked at the association of the intermittent and constant pain using that ICOPE scale with radiographic changes. And we saw that there was actually quite a nice trend. Again, basically it matched what I was telling you, that the lower scale grades had more intermittent pain and the higher, more constant pain. So that was really nice to see that symmetry between the qualitative and the quantitative studies.
Do we know why people with earlier stages are more intermittent and later stages more constant?
I don't think we do at this point. Certainly, I think, we could suggest that people in the later stage might have higher level of consistent inflammation in their knee, but we've seen that as well, that there is inflammation present in early disease. So yeah, I'm not 100% sure. I know one of our phenotyping studies where we were looking at early disease and we were looking at some MRI features found that meniscal extrusion, out of all the MRI features that we were looking at, meniscal extrusion was one of the features that kind of came out within the phenotypes. That could be something that could be more mechanically sensitive, perhaps, if something's extruding from the joint and might get caught or pinched at times, that could be a source of mechanical pain. But, nobody's really looked at that to my knowledge. I'm just kind of hypothesizing based on those phenotyping studies. So we don't really know for sure what that is. I know Tom Appleton, his lab at Western, they, I think, just had a study out last year or so that looked at the ICOPE and its association with the fusion synovitis and found, I believe, a higher association with the constant pain subscale there.
When we talk about constant pain, is this similar to non-weight-bearing pain?
I mean, yes and no. Certainly, if somebody has constant pain, they would have it when they're not weight bearing, but they would equally have it when they are weight bearing. If it's there all the time, it's there regardless of what they're doing, and it may or may not be made worse by weight bearing. And often people will complain that their pain gets worse at night. People that are going towards joint replacement, that's usually one of the things that surgeons are looking for, is that they have this high intensity of pain and that it's disrupting their sleep, keeping them up at night, that kind of thing. It's constant, it's constant. It doesn't matter really what they're doing.
So, in other words, people with more progressed stages of OA would have more non-weight-bearing pain.
Usually, yes.
So, one of the studies you co-authored in 2022 examined the potential mechanisms of weight-bearing versus non-weight-bearing pain. And it's an interesting study, and the findings I find really interesting. Can you briefly describe the study and what you find, and then we'll go from there?
I think it's important to understand first and foremost that the weight-bearing and non-weight-bearing pain, they used items from the WOMAC scale. Okay, so we're talking about a self-report scale here. We're not talking about, for example, bringing someone into a lab, having them do certain movements and asking them about their pain and then having them sitting and relaxing or whatever, right? So because we know there's a difference between self-reported questionnaires and performance measures. So I think that's the first thing to understand about this study. We're talking about self-reported measures. So it looked at sensitization, peripheral and central sensitization, differences in these weight-bearing and non-weight-bearing questions. And basically, they didn't see the differences that they thought they would. They were kind of hypothesizing that with weight-bearing that they would see greater sensitization than with non-weight-bearing. But that was true in some of the tests, but it wasn't consistent. And the difference in the effect sizes were not that big that we would look at them and go, oh, yeah, like that's a big difference between sensitization and weight bearing versus non-weight bearing. They were relatively close, I would say, that you wouldn't make a big deal out of it. So that was a surprising finding. It was obviously against their initial hypotheses. And, again, it speaks to the fact that we don't fully understand these mechanisms that are underlying things. and that, for example, having this low-grade inflammation could easily be something that can skew those findings, right? You could have sensitization because of that at rest in a non-weight bearing position, equally in weight bearing. So definitely more work needs to be done there. But I do think it was valuable, even though the results are not what we had hypothesized. It then, gives us further understanding, okay, that we need to look further and try and do more work to clarify what's going on here.
So this research particularly points to our not knowing of what the pain mechanisms underlie if we are able to differentiate the mechanism behind weight-bearing pain versus non-weight-bearing pain, right? And now with what your research of pain phenotyping is looking at, you're trying to incorporate some of those sensitization measures and psychological measures and trying to phenotype patients.
Or
Subgroup patients. We've talked about the word phenotype a few times, but just to provide clarity, what is phenotype in the context of pain research?
So there's a few different definitions out there. There's kind of a typical medical definition of a phenotype, which it's a combination of observed characteristics, including behavioral things, and it can include genetic aspects. Often that's something that people will associate with the word phenotype. In terms of pain research, there's been the IMPACT group. They've been around for a long time, the Initiative on Methods and Measurement of Pain Assessment in Clinical Trials. They put out a paper, I think in 2016, where they made some very concrete recommendations for phenotyping pain research. And they provided a slightly different definition that basically says it includes self-report measures. It includes as well the quantitative sensory testing. And they said, kind of, here are all the things you should be measuring. Here's the way that you can measure them. And it really encompasses what I think, to the best that we can at this point, these biological, psychological, social aspects, and embodies the neuromatrix model of pain.
To put it in short, this impact group in 2016 recommended that researchers measure more than just the imaging findings of the knee, to also measure some quantitative sensory testing, some psychological measures, sleep, etc., to help subgroup knee osteoarthritis patients.
Yeah, but it wasn't specific to knee OA. This was pain research in general.
I see.
There was a different group that I was part of. I think the paper was out in 2020. We had a consensus group where we published recommendations for research methods for phenotyping research, as well as consensus statements on what phenotyping is and what it means for knee osteoarthritis. So that would be a bit more specific to knee osteoarthritis.
So what is the ultimate question that phenotyping research is trying to answer?
Well, I think ultimately where we'd like to get, and we've been slow to move towards for a variety of reasons, is that we want to be able to phenotype people to treat them more effectively. As I was saying at the beginning, the more that we can tailor our treatments to the person, the individual in front of us, they can walk through the door, we can talk with them, do a physical exam, identify certain defining features, and based on those features, we can go, okay, yeah, you're in this subgroup, and here's what we need to do for you. If we can get to that point, then I think that's kind of the holy grail, and not just for knee osteoarthritis, but for, again, any kind of musculoskeletal disorder, any health disorder, really. Where we've been so far, and certainly my work has focused on understanding the pain mechanisms, what's contributing to people's pain, what's making their pain worsen over time, that kind of thing. The phenotyping research is very challenging because we need large data sets, and they quite frankly just don't exist, a lot of them. And in order to, let's just take some of the studies I've done, right? There is a study in the US that's been going on for a number of years that has this longitudinal cohort that we've been using to do these phenotyping studies, and it does have a few thousand people in it, so that's great. So we'll do a study, we have these findings. In order to know whether our findings are actually valid, ideally, we need to replicate those in another data set. But as I've said, and because, as you pointed out, I use QST in my studies, there isn't another data set that's been available that has this longitudinal cohort that has QST in it. I've just recently heard of one that might be an option now, but without being able to validate our findings and say, yeah, okay, we're able to replicate this, it seems like that these findings are generalizable to people in general, then we can't make that leap to, okay, yeah, we're going to now start using this information to look at treatment, for example, or what have you, right? We could do that, but it's kind of be missing some steps in between. And there'd have to be other evidence that would come out that'd be quite convincing to persuade you to jump to that treatment part and apply that phenotyping results there.
I've come across perhaps some phenotyping research in low back pain, and there's an argument to make that, well, really, each person is an N of one, is of their own subgroup.
Yeah.
Does that argument come across in your line of research?
Occasionally, I'll hear people talking about that. We're at a point, I think, with the phenotyping research in NEOA that there's so much heterogeneity, and people are proposing different phenotypes and different subgroups still on an ongoing basis as the evidence evolves. And so we're not even sure of how many phenotypes there are, right? There's different kind of domains of phenotypes that people are investigating. To say that there's an N of one, I think there's certainly some truth to that, but then can we agree at what all the things are that we should be looking at within that individual? I don't know that we're even there yet.
Absolutely. So what have you found so far?
I think most interesting findings that we had was one of the first studies I did back in 2019, where, as I said, we used this cohort data from the US. It's called the MOST cohort, multicenter osteoarthritis study. We took a group of people that were essentially free of pain for a 2-month period. So we asked them if they had pain on most days of the month in the previous month, and they were asked that 2 months in a row, basically. So over a 2-month period, we took the people that basically said they did not have pain on most days of the month. And then our outcome was 2 years later. We wanted to see of those people who went on to develop having pain on most days of the month. So the opposite now. So they've gone from essentially non-painful for 2 months to consistently painful. We conducted sort of phenotyping study where we used a combination of quantitative sensory tests and psychological variables that are available in this data set. So we're, of course, limited to what we can study in the phenotypes based on what's in the data set. And so what was really interesting was, so we found 4 phenotypes, and 2 of them in particular were dominated. They were all really dominated by the quantitative sensory tests, but 2 of them in particular more so. And one of them was very strongly mix of PPT and temporal summation sensitization, and the other one was more temporal summation. And the self-report measures about depressive symptoms, pain catastrophizing, sleep quality, widespread pain really did not factor into the makeup of these phenotypes at all. They were not able to distinguish between the phenotypes, only the quantitative sensory tests. And the people that were in the group with the greatest level of sensitization with this combined PPT and TS findings were twice as likely compared to any other group to go on to develop consistent pain 2 years later. And to me, that kind of made sense because we're talking to people at the beginning who don't have a lot of pain, then it makes sense to me that they wouldn't have the psychosocial stuff to go along with it so much, right? Based on those baseline characteristics, that's where we made the phenotypes off of. But then it also indicates that even when people aren't in a lot of pain, there is this baseline level of sensitization there that seems to be able to determine who's going on to develop consistent pain. And so that's really interesting, and saying that that might be something that we need to find a way to intervene on, which we haven't as yet.
Do we have any clue where this baseline sensitization came from? Is it like a genetic thing, or is it a part of the disease, or a part of growing up?
I mean, in this particular case, we don't. I can tell you that, again, Tahina Niyoji, who's my collaborator there, this cohort study, a lot of the investigators are in Boston, and they did a study, I wasn't part of it, where she looked at whether sensitization was a trait or a state in this cohort. And her conclusion, based on her findings, she said that it suggested that it's more of a trait. And we've also seen, there's another fellow postdoc with her, just did a trajectory analysis of sensitization over a number of years, and also found that it was pretty steady and consistent. Yeah, I don't know what the answer is to your question, but there certainly is, within the NEOA evidence in this cohort, there seems to be a suggestion that it is something that's kind of stable. How it starts, that is a question that remains to be answered. If we look back early enough, we just had some papers out about phenotyping in early NEOA. If we're thinking about the disease process and the fact that there are things happening in those soft tissues that we're not seeing on an X-ray, right? And I'm not suggesting that everybody has to get an MRI so that we can understand that, but on some kind of, molecular level, cellular level, there are things happening in the joint very early on that, even in the absence of pain, could be altering how nerves are functioning and their responsiveness. That is creating a certain level of sensitivity that goes on at a certain point in time, might become more associated or significant with a person's pain experience. But I think there's things happening there prior to someone probably being in pain, and that can contribute to that and be setting things up. And that we just don't know enough about yet.
Very cool, very interesting. So this group of people you were looking at, from no pain most days to having pain most days, turns out that their pain system sensitization differentiate or predicts this trajectory more so than some of the self-reported measures. You have an opposite finding in another group, right?
Something important to understand. So I think you're referring to the fact, so I did a different study of phenotyping, and we found the opposite, in the sense that the self-report measures were the things that differentiated between the three groups that we found, and the QST, with the exception of temporal summation, did not. So what's important to understand about the differences in these two studies is the sample. So as I said, in the first group, we took people who were essentially pain-free. They were also community dwelling. Comes from a longitudinal cohort. And so, we're not taking them from physician visits or things like that. This other study I did, we sampled people who had their first consultation with an orthopedic surgeon. And so I think it's fair to say these people were in pain, a decent amount of pain, probably maybe wanting to consider surgery. Also, the phenotyping that we did, we tried to model it after the impact recommendations, that impact paper that I mentioned. So we had a lot more self-report measures as well than the pain susceptibility phenotypes. And again, this kind of makes sense to me, like how I was saying, in the susceptibility paper, people weren't in pain, and so it made sense that the psychosocial stuff didn't pan out. Here we've got people in a lot of pain. And so are they going to have disturbed sleep? Are they going to be fatigued? Are they going to have anxiodepressive symptoms? Yeah, highly likely, right? And we also, in terms of stage of disease, so in the first study, we had a mix of disease, but I think it was about 40 some odd percent had what we would call established NEOA on X-ray. Versus the group seeing the orthopedic surgeon, they tended to be more towards end stage in the ratings that we do for X-rays. as that structural change in the joint was further along and maybe they had worse inflammation, and we know that the changes to the nerves in the joint and their thresholds will change over time and they'll become lower and more receptive. So it makes sense to me that because we had a group that were more towards end stage, that they were kind of more similar that way. And we wouldn't necessarily see QST being able to distinguish between them because they were probably all experiencing similar levels of sensitization, so to speak, versus, again, in the previous paper, we had fewer people with established OA, a more heterogeneous group, and that may contribute to that, combined with not having a lot of pains.
So just to clarify, this latter group we're talking about, what's the time point one and the time point two that you're...
Oh, yeah, sorry, that's a good point. This second paper was just cross-sectional, so we didn't have a longitudinal follow-up. We just examined what the phenotypes were and described who was in them, like the characteristics of the people.
So these are the two main phenotyping studies you have conducted, or are there more?
Yeah, there's a few more. I just had a PhD student graduate in December, Raghava Nilapala, and his thesis was about phenotyping in early knee-OA. So his first study, again, we used this most cohort data, and we just looked at people in early stage, which nobody had ever done before. So looking at people with KL grade 2 or less. So KL grade 2 is considered to be indicative of having established knee OA on X-ray. And we did try to look longitudinally in this study to see who would go on to experience pain worsening. But over a 2-year period, we unfortunately didn't have that many people that had clinically important change in pain as well as progression in their knee OA status, because we wanted to look at that progression, so going from early to kind of a different stage. We also we gave a more complex definition of people coming in. We wanted to kind of move away from just pain intensity ratings. And so we included the intermittent and constant pain. And based on that research that I told you about that said that people with early stage disease have more intermittent pain, that was part of our sample inclusion, was to bring in people who had intermittent pain only and not constant pain. And so part of our follow-up 2 years later was to see people progress to having more intermittent pain and constant pain. And there was very few people, as well as a change in pain intensity. And there's very few people that had that combination of things. But we did, similar to the previous work I've done, we saw that basically the quantitative sensory piece was there, was able to distinguish between people, as well as certain psychosocial factors. And one of the novel things about this study was that we looked at 2 different models where we included MRI and some other factors, gait, comorbidities, and muscle strength in the phenotyping model to see whether we would see any contribution from these variables. And we saw that including them seemed to increase our understanding of the phenotypes and who was in them. And then his second study kind of took the phenotypes that we modeled in the pain susceptibility paper and looked at them over time, over a period of 7 years, to see what happens to them. Because, we didn't have any understanding of that. People have done trajectory analysis, but with trajectory analysis, you can only look at one variable at a time. So they often will just look at pain intensity and what happens to that. So we were able to look at the pain phenotypes themselves and what happened to them over 7 years. And again, we found that they were extremely stable. I think it was about 86% of the people stayed in the original group that they were put in. And a few people got worse, a few people got better, but there really wasn't a lot of movement. So again, that stability is interesting.
If you were to give clinicians listening one line takeaway, a couple lines, it's okay. What can we know from these couple of pain phenotyping research? And if there's any utility in how we think about knee OA management today.
As far as understanding all the different things that may contribute to a pain phenotype, we're not, 100% clear on what that is yet. That being said, we can say that quantitative sensory measures and some psychosocial factors do seem to have some consistent role in making those phenotypes regardless of stage of disease. But depending on where you're looking, they may be, have more or less prominent role. And then certainly how much pain the person is actually in also seems to influence, for example, that prominence of sensitization versus psychosocial factors. It's really interesting to me that over a period of 7 years that most of the people stayed in the group that they were originally in. And I think that's kind of comforting in a way, certainly from a treatment perspective, right? And it aligns with our understanding of the disease being very slow and progressive over a number of years. So I think that's helpful for clinicians in trying to tailor their treatment, knowing that the majority of these people are going to stay within that original profile, so to speak, for quite some time, even as they progress through the disease a bit. And so that should hopefully make things a little bit easier to manage and treat. At the end of the day, we still do not have any disease-modifying medications. We know that opioids obviously don't do much, and nor are they recommended. People can't stay on NSAIDs because of complications. And so we don't really have any good medications for pain management. We've got this doubt about exercise. There's lots of work to be done still.
Does it give you a gloomy picture or an optimistic picture?
No, I like to stay optimistic about it because there's so much to do and so much to be understood. And I know lots of colleagues who are working on drug development. There's apparently some exciting things going on there that I don't know enough about to speak to in detail, but they're really hoping that there'll be some exciting findings in the next relatively short period of time, like 1 to 2 years type of thing. I know these weight loss drugs have really been creating quite a lot of noise as well, because not only are people with knee OA who have put on a lot of weight, which has implications for the joint, it also seems it's having systemic effects because there's like a metabolic component to the disease that people are very excited about as well. Again, it's an area of research that's young and there's still a lot of work to be done to understand what's going on, but we need long-term studies to kind of understand these long-term effects of being on these drugs. So there's lots of exciting things happening, and hopefully we'll have some good news in the next few years from that drug side of things to help people in terms of day-to-day pain management.
Yeah, I guess we've sort of also touched on from your line of research what you're hoping to accomplish eventually. What are some immediate next steps that you're working on right now?
So one of the things that really has me excited is in the face of a lack of a good medication right now, and especially with this evidence that came out about exercise, I'm really interested in neuromodulation. And so I have a couple of pilot studies that one we finished, and I'm trying to get funding for the full study now. We designed a intervention called pain-informed movement, where we combined regular strengthening, kind of neuromuscular strengthening, with mind-body techniques for more of an overall nervous system modulatory effect. And we also used pain neuroscience education. We're really trying to target things from all angles, so to speak, and trying to maximize our endogenous modulation capabilities. The other pilot that I have going on right now is combining non-invasive brain stimulation in the form of TDCS with yoga. And the idea behind that is that we're combining a form of internal modulation with an external form. And again, thinking about whether combining the two would lead to better effects than just one or the other. But the premise is kind of the same: is what can we do to harness our endogenous modulation as much as possible while we wait for something else to come along.
Yeah, it's just amazed again. So many directions of research you can take with NEOA. For our listeners, we have an episode on pain-informed movement. It's episode 23 with Neil Pearson, and I really liked that episode. I highly recommend giving it a listen to understand what it is and how you might be able to apply that in your clinical practice.
Yeah, that's the goal. So Neil is a collaborator on the study, and yeah, I'm really hoping that we get the funding to bring it to a full trial, and then if we get favorable results, then we're going to try and roll it out so that we can teach clinicians how to implement it in practice.
Thank you so much for sharing it. It's very exciting work that you're doing, and all the best.
Thank you for having me.
Thank you for listening to this episode on knee osteoarthritis pain. If you want to read more about the topic, I've included some articles and links in the show notes. Paincast is a freely available resource for you to advance your knowledge about pain and physiotherapy. We will continue to provide you with top-notch, evidence-based, and practically oriented content. To help more people know about this amazing resource, follow us, rate us, and share our content with your network. Follow us on Instagram at paincast.psd, where you'll find bite-sized knowledge in 1 to 2 minutes. You can also use the feedback form linked in the show notes to help us improve. Thank you again, and stay tuned for future episodes on pain and physiotherapy.